to start?
You can go ahead.
Yeah, okay.
Yeah.
All right. السلام عليكم. مساء الخير عندكم. احنا لسه عنا الدنيا الصبح. أنا اسمي ربع عزام. أنا دكتورة أطفال جهاز هضمي وأمراض كبد وزراعة كبد. بشتغل باليونيفرسيتي of Chicago. I've been there for like 15 and a half years. خلصت من الجامعة الأردنية طب وبعدين اجيت على أمريكا وعملت تخصص أطفال وبعدين GI وtransplant hepatology. اليوم I'm going to be talking to you a very clinical subject. So you all read books and literature and mashallah alaykum. What I am going to be discussing with you today is more of clinical. When you look at these liver panels, how to think about them and what your differential diagnosis should be looking like and what is number one on your differential and what comes next and all that stuff. So I think it will be about 45 minutes. It's open for discussion. If you want to interrupt me, that is okay, though I prefer that you keep your questions till the end of the lecture. All right. All right, so there are two portions for this talk. The first one will go over common causes of abnormal liver function tests, and the second one is about the jaundice in babies and what the guidelines are and how to think about them. All right, so I really do not know what you call liver panels back home. Here, at least at many hospitals, they are called liver function test, and this is a misnomer because not much on the panel really tells you about the functions of the liver, but it leads you towards the source of the damage. So what does that mean? So elevation in the transaminases, ALT and AST, out of proportion to alkaline phosphatase and bilirubin usually tells you that there is a hepatocellular disease, so more of cellular rather than biliary. And elevation in alkaline phosphatase and bilirubin in disproportion to ALT and AST denotes a cholestatic pattern, so more of a biliary pattern. The actual function of the liver is really not based on these numbers specifically, but on the functions that the liver has to make, and these are making proteins. So these are the albumin levels and the clotting factors, so PT-INR, which is a vitamin K dependent factor. All right, so ALT, if you do not call them ALT back home, then they are the SGPTs. And these are more specific to the liver, though they also get released from muscles, but at a much lower levels. They have longer half-life than the AST, which is the other transaminase that also is released from the liver. It's about 24 hours. The AST is the second transaminase, and the other name for it is the SGOT. And this is less specific for the liver than the ALT, as it comes from other organs, including muscles, heart muscle, skeletal muscle, kidney, brain, pancreas, lung, leukocytes, and red blood cells. The third parameter on the liver chemistry panel is the alkaline phosphatase, and this is released by the liver, kidney, bone, intestines, placenta, and white cells. And the normal values, as you know, vary by age because as kids grow and they develop bone-wise, their alkaline phosphatase also gets higher, normally higher. Low levels are those seen in patients who have zinc deficiency, and it's one of these things that we look at as flags to make us think about Wilson disease, which is the copper accumulation disease. The fourth parameter is the gamma-glutamyl transpeptidase, the GGT, and we always think about it as a biliary marker, especially when the alkaline phosphatase is elevated. So it, though, does not come just from the biliary epithelium, but it comes out of the kidney, pancreas, spleen, brain, small intestine, and breast. And it helps us differentiate whether the alkaline phosphatase elevation is due to liver disease, biliary disease, or bone disease. So if the alkaline phosphatase is elevated and the GGT is normal, then you're probably dealing with a bone disease. Nonetheless, there are cholestatic liver diseases where the alkaline phosphatase is low, the bilirubin, direct bilirubin is elevated, but the GGT is low. And these are very few liver diseases, like you could count them even on 1.5 hands. GGT is known to be elevated in neonates, and it stays elevated for the first month of life. In our lab, the normal is up to 60, but for babies, we take up to 100 as normal. We have to be aware that GGT elevation sometimes is just related to medications patients are on, especially if they are on anticonvulsants, especially phenobarb. So if a patient is on a phenobarb treatment, then and you had to check their liver panel for any reason and you added the GGT, that GGT is not going to help you whatsoever, because you could see it in thousands sometimes or several hundreds, but it's really related to the use of the anticonvulsants rather than a biliary problem. The fifth one is bilirubin, and usually liver panels have the total bilirubin and then the direct and indirect. And I'm concentrating here on the direct bilirubin because it's a marker of a liver disease, and usually it denotes one of two things, either biliary obstruction or hepatobiliary dysfunction. And we're gonna go over some scenarios. Occasionally though, the direct bilirubin is elevated and the rest of the liver panel is completely normal. And these are the two genetic problems, Dubin-Johnson, which is the black liver, or Rotter. So only exclusively elevation in direct bilirubin level. So all that was not function. So what are the functions measured by? The first one is protein, albumin, and albumin is only synthesized in the liver. So when you have a patient with hypoalbuminemia, things that should come to mind are either the patient is not getting enough protein in their diet, or they are not making enough protein, and that's liver disease, or they are losing protein, and then you will have to check their urine and their GI losses. So for the urine, you will start with a regular urine analysis and chemistry, looking for how many pluses of protein, and then you take that route of evaluating for nephrotic syndrome or others. And for GI losses, you will do alpha-1 antitrypsin in the stool, not in the blood. And we have always to remember that albumin is not reflective of the acute injury of the liver or the acute significant loss of liver synthetic function, because the T half-life is 20 days. So it takes time for the albumin to start reflecting the synthetic dysfunction of the liver. The prothrombin time, PT, INR, to be able to compare it to other labs, is more specific and is very quick to reflect the dysfunction of the liver. If it's prolonged, then you have to think about whether this is real prolongation and synthetic dysfunction, or that it is loss of vitamin K or malabsorption of vitamin K or inadequate vitamin K. So the right thing to do is to give a dose, and we usually give IV vitamin K, and I'm saying IV with like underscoring the importance of giving it very slowly so that the patient doesn't go in cardiorespiratory arrest. We usually put it in normal saline and we infuse it over at least 30 minutes. And then at least 6 hours later, you can repeat the INR panel, and if it's normal, then you will know it's not synthetic dysfunction of the liver. And the factors that lead to the measurement of that number of PT are, as you may remember, 1972. So factor 2, factor 7, factor 9, and factor 10. All right, so you do have a patient with abnormal panel and elevated transaminases. So what big categories should come to mind? So infection is one, and whether it's a viral infection, bacterial infection, fungal infection, all these could coincide with abnormal transaminases. either due to the infection itself, like hepatitis infection, infectious hepatitis, B, C, A, all these, CMV, EBV, adenovirus, herpes, or that there is some category called bystander. So the body is dealing with something going on and the liver is reflective of what's going on in the rest of the body or in another organ. The second group is metabolic diseases. And those metabolic diseases are a huge group of inborn errors of metabolism. So these are seen in the younger ones. The other ones are the Wilson disease, copper metabolism problem, iron, hemochromatosis, and many others. Autoimmune diseases, the biggest, of course, in this group is autoimmune hepatitis, and whether it's type 1 or type 2, it doesn't matter. It does present with abnormal panel. Primary sclerosing cholangitis, you could add it here, though not necessarily it's always autoimmune related. So autoimmune cholangitis is more reflective of one of these differentials in this group. Celiac disease, 9% of abnormal LFT panels are really celiac related. And as you know, celiac disease is one of these autoimmune diseases. Infiltrative process like leukemia or any of these tumors that can infiltrate the liver or occupy some portion of the liver. Ischemia. So if the patient's blood pressure significantly drops for some prolonged time, then the liver that is dually blood supplied will have that sensed. And when that happens, then there is necrosis of the hepatocytes, and that leads to release of AST and ALT. Myopathy. So that's not a liver disease. As I mentioned in the first few slides, ALT and AST are secreted by the muscles as well as the liver. So sometimes you will be faced with abnormal panel that is really only reflective of muscular disease rather than liver disease. And for that, you will be checking a CPK. And the last category here is drug toxicity. You always have to ask your patient about what medications they are on. And many times it's related to what they are receiving at that point or what they had received within the past 3 months before being on, before having that liver panel checked. Now, one of the big categories, of course, are the anticonvulsants that cause drug toxicity, but you always have to remember that antibiotics that sometimes we sprinkle on patients as water have a high possibility of causing drug-induced liver injury. And the biggest in this group is augmentin, so amoxicillin, clavulanic acid. The other medication that is also common, especially for teenagers causing their drug toxicity or drug-induced liver disease, is monocycline. And you always have to remember acetaminophen. That is the biggest out of all of them. So when we talk about drug toxicity, we actually have them in 2 big groups. The first one is acetaminophen, and the second one is the non-acetaminophen. All right, so now that you have the abnormal liver panel and you have categories in mind, how to put them as which one is more possible than the other. So usually the highest elevation in transaminases, the ALT and AST, are seen in ischemic hepatitis. And this is because if you remember the lobule of the liver, there is the portal triad, and I'm sorry, I don't have a picture. I planned to add one and I completely forgot. So the portal triad has the liver lobule has the portal triads on the sides, and in the middle is the central vein, which is the hepatic vein that drains up to the heart. So the ALT and AST area is around that central vein. So when ischemia happens, it starts with the portal area, and the portal area has the portal vein and the hepatic artery. So blood supply is cut off from there. And the furthest away from this area will be around the central vein. So since the area around the central vein has most of the release of the AST and the AST, then the necrosis of that area will release a lot of them because it's under less oxygen pressure. And usually it could be even up to 10,000 international units per deciliter. Drug-induced liver injury is also second in line for how high these transaminases could go up to. So sometimes 2,000, 3,000, that is not uncommon. Now, every medication has kind of a way to present when it causes liver injury. So some medications cause the significant elevation of the transaminases like ischemic hepatitis. That's, for example, acetaminophen. Some other diseases present with what looks like autoimmune presentation, and that is minocycline. And some medications could cause cholestatic injury, and that's, for example, augmentin. So usually when you decide whether the liver panel is reflective of drug-induced injury or not, you always have to take into consideration how these medications present their toxicity. And of course, there is always the idiosyncratic, where not commonly reported that that medication causes drug-induced injury, but in some patients, it is able to. Third in line is viral hepatitis. So, and these include the A, B, C, and as you know, hepatitis A is common. I hope that you are paying attention to vaccinating all your patients with the 2 doses of hepatitis A. It's common to be contracted through the oral fecal route. It causes significant elevation in the ALT and AST with jaundice. And usually in little kids, it's very well tolerated, while in adults, it could lead to acute liver failure. Autoimmune hepatitis, usually the enzyme elevation is several hundreds. Nonetheless, it could be like 1,000 to 2,000, especially in acute liver failure presentation of autoimmune hepatitis. And I'm going to give you some other flags in the liver panel that will make you think more of autoimmune hepatitis. Chronic hepatitis. So these patients usually present with a few hundred elevation of the ALT, AST. And cirrhosis is when the liver is scarred more than having normal healthy hepatocytes. And those patients could have completely normal looking liver panel in regards to the aminotransferases. Nonetheless, they probably, and I'm saying probably because sometimes you catch them a little early, where their albumin level is normal, not reflective of the synthetic dysfunction, or you could catch them without jaundice, and that's when they have compensated cirrhosis rather than decompensated cirrhosis. All right, when you see patients with AST elevation much higher than the ALT, then you have to widen your differential diagnosis. So you should be thinking about hemolysis, where the RBCs are releasing all the AST and more than the ALT. There is no ALT there, very little, if any. Or muscular disease, so rhabdomyolysis, myopathic diseases, spinal muscular atrophy. Always pay attention to the history. So I do remember a few years ago, I had a referral of a 3-year-old boy for abnormal liver panel, and just taking the history, you get a lot. So the patient did not have jaundice, the patient did not have abdominal pain, but when I asked about development, the parents stated that he was doing fine, and more recently, he would not be able to walk up the stairs, and they had to carry him. So immediately, it just sounded like a muscle disease rather than a liver disease. And of course, his CPK was 15,000. So instead of like 150. So again, the history will many times lead you to know what your differential should look like. All right, vigorous exercise can also lead to elevation of the AST. Occasionally, you will see patients who have AST at high levels and everything else is normal. They have no hemolysis, their liver panels look normal, their synthetic function is normal, their physical exam is normal. And there is an entity called macro AST, where the AST kind of combines with immunoglobulins and makes a bigger molecule or some bigger portion that cannot be excreted from the kidney, and it stays in the blood, and then the measurement is high. This could be familial, and it could be brief and resolves with time, and it doesn't require further evaluation. All right. Flags on the history that will make you think of certain liver diseases more than others. So remember that liver disease does not have symptoms. It's usually asymptomatic. Though we say fatigue is maybe the most common symptom, but fatigue is shared by many diseases and no medical problems as well. If the patient has jaundice or itching, fatigue, abdominal pain, abnormal bleeding, then you'll definitely have to be thinking about the biggest categories of liver disease, and then you will go down that route rather than thinking about some other organ in the body. Itching usually signifies biliary obstruction or cholestatic disease. Fatigue is very non-specific. Abdominal pain is non-specific. Could be hepatitis, could be even non-alcoholic fatty liver. 40% of them have abdominal pain. Abnormal bleeding signifies synthetic dysfunction. Dark urine and acolic stools do signify biliary obstruction. It could be a stone, it could be a choledochal cyst, could be biliary atresia, could be tumor. Forgetfulness and decreased school performance, that tells you that their ammonia level is elevated, and that happens in liver synthetic dysfunction or liver failure, whether it's acute on chronic or chronic. Over time, they lose more of the healthy cells and they cannot do the functions of the liver, or of course, acute liver failure in the few days or week or so before they come for further evaluation. Altered mental status is always a big thing for acute liver failure. Many times those altered usually come with, of course, abnormal liver panel, but sometimes with jaundice. So it makes you think more of a liver disease rather than, for example, a primary neurologic dysfunction. Nonetheless, of course, the brain is part of all these organs that get affected if the liver is dysfunctional. Starvation or malnutrition can also cause fatty liver, and this is the lean NASH or lean NAFLD. So the liver panel will be abnormal. Viral illnesses in the near past before the presentation with abnormal liver panels, it could be still viral hepatitis process, or many times viral diseases bring up a dormant liver disease up to the surface. And this is very common in autoimmune diseases where patients had a viral illness or bronchitis, tonsillitis, and then a couple of weeks later, they are jaundiced. Of course, you cannot say it is only like whatever this presentation looks like. It could be also the medications that they were placed on. So medications, again, is very important to be checked with parents and not to forget about the details. For example, again, from history, when I was a fellow, there was a patient who had multi-organ failure, and almost every single subspecialty had seen the patient before they called the liver service. And the one thing that all these services did not take history of was medications. And it turned out that this mom was giving her son, who was almost 2, 10,000 units of vitamin A every single day. So he had vitamin A intoxication, basically, with cirrhosis and liver failure. A personal history of inflammatory bowel disease. So you know that IBD patients are at high risk to have primary sclerosing cholangitis or autoimmune cholangitis, or even autoimmune hepatitis. If the patient had another autoimmune disease, like celiac disease, for example, they are at risk for abnormal LFTs that corrects once they are on the gluten-free diet, but they are also at risk for autoimmune hepatitis and for sclerosing cholangitis as well. Personal history of obesity, of course, that will make you think of non-alcoholic fatty liver disease, or even rapid changes in weight, like very significant increase or very significant decrease. History of diabetes will also make you think about fatty liver or glycogenated liver causing the abnormal liver panel. And family history of autoimmune disease. So it's always important to ask about autoimmune diseases and not just the category of autoimmune. You have to give your patient or the families examples of what these are so that they are able to tell you whether they have that family history or not. So lupus, rheumatoid arthritis, autoimmune thyroiditis, Hashimoto's, inflammatory bowel disease. So you have to mention a few till you start getting these answers. Diabetes in kids, so type 1 diabetes, or vitiligo. Vitiligo, I've caught a couple of autoimmune hepatitis in my patients with family history of vitiligo. And of course, if the family has a specific liver disease like hemochromatosis, hereditary hemochromatosis, then you will know that you're probably dealing with that, though we do not see it in the younger children. You could start seeing that in older adolescents as just abnormal, slight abnormality in their liver panel. Family history of emphysema should make you think about alpha-1 antitrypsin deficiency. And this disease, we always thought about it as a European disease, but nonetheless, I checked the literature yesterday to see whether we Arabs developed that, have it. And yes, it is reported in almost everyone. Arabs, Mediterraneans, Europeans, African Americans, Asians, South Asians, East Asians. So that is one that can lead to, it can present with jaundice in babies, it can lead to cirrhosis in younger children, and it can have a manifestation of chronic lung disease in the older ones. All right, when you have the patient, one thing I always tell my residents and my fellows is when they examine the patient, there are few things that could make them think more of a chronic liver process rather than acute liver process. And in that, you are really looking for signs of chronic liver disease. And those signs starting from head to toes, starting with the eyes, then you will see jaundice. The other area that you will look for jaundice other than their whole skin is under the tongue. When you look at their, when you listen to their heart, there could be hyperdynamic heart sounds. You could hear a murmur, flow murmur. When you examine their abdomen, you could either feel the big liver, the hepatomegaly with firm to hard edge. If it's significantly enlarged, you could even feel some of its surface between the margin, the lower margin, and the lower margin of the rib cage. Or in significant cirrhotic patients, you will not feel their liver. And of course, you have always to start from the right right iliac crest and going up so that you do not miss a hepatomegaly. But if you do not feel it, and you are seeing a liver patient, a chronic liver patient, it's not uncommon that their liver is like as small as this liver of liver, where you really cannot palpate it. You could probably percuss it and it will be a few centimeters. So that's the shrunk liver in long-standing cirrhosis. And those patients usually have a huge spleen that could extend all the way down to the other side, so to the right iliac crest. And usually it pops up out of their abdomen. With that, usually they have some degree of ascites, moderate to large. Increased intra-abdominal pressure will cause hernias, so always check for hernias. And then you will do their neurological exam, and this is very important in both chronic and acute liver failures. You will have to choose things that are appropriate for age. So the name, the parent's name, the age, the location, date of birth. I always, for my acute liver failures, I always have them write their name and the date every single morning. And as their encephalopathy goes worse, you will see that their handwriting becomes very disturbed and not neat. On the skin itself, and of course, with the neurologic, just staying at the neurologic, you'll have to do reflexes and see what hyper or hyporeflexia they have and whether the Babinski is up or not present. On the skin, starting with, of course, the jaundice throughout, the telangiectasias on the face, the spider angiomas on the top of the chest, the palmar erythema inside both palms, Dupuytren contractures, and clubbing. These are big signs of chronic liver disease that you will not see in acute liver failures. Usually acute liver failures might have maybe a slight hepatomegaly. They will not have splenomegaly. On presentation, they will not have ascites most of the time. Ascites happens with fluid overload that could happen, or as their liver suddenly shrinks. So that gives sudden portal hypertension and development of some ascites. Their neurologic exam is very important, and we always have neurochecks on an hourly basis. You will not find the rest of the manifestations, maybe jaundice. but not all acute liver failures are necessarily jaundice at the start. Like acetaminophen acute liver failure, this is an anicteric acute liver failure. All right, helpful flags on the liver panel itself. The first one, if you see a wide gap between total protein and albumin, like globulins of 4 and above, think about autoimmune hepatitis. If you have a patient with low alkaline phosphatase and mild elevation in transaminases like 100, 200, usually not higher than that, though I've seen 600 and 700, then think of Wilson's disease. So the big thing on their panel is the very low alkaline phosphatase. It could be like 50. Nonetheless, not all Wilson's patients follow the books, and you will see Wilson's patients whose alkaline phosphatase is 100. Low albumin, so synthetic dysfunction is low, direct bilirubin elevated, mild transaminases where the AST is higher than the ALT, and abnormal coagulation. That tells you that you are dealing with a chronic liver disease with some degree of dysfunction. It could be a cirrhotic process. And because the direct bilirubin is elevated and the INR, mostly because the direct bilirubin is elevated, those patients are in the decompensated cirrhosis category. Normal albumin, direct bilirubin elevated, very high transaminases, and prolonged PT. So the prolonged PT puts them at the category or in the category of acute liver failure. Very high transaminases. Bilirubin is elevated, but normal albumin. That process that causes the albumin to go down has not yet been sufficient in length to cause the albumin to go down. So that is acute liver failure. And of course, the differential is very long, needs another talk. Number 5, normal albumin. Bilirubin is normal, very high transaminases, and prolonged PT. So the coagulation is abnormal. The transaminases are very elevated. And again, the albumin is normal. So just because the prolonged INR is elevated and the transaminases are very elevated, you're going to be thinking about an acute process. It could be an ischemic process. It could be a medication process, again, with anicteric hepatitis. Transaminitis with normal rest of the panel and normal liver exam, then think that this is possibly muscle rather than liver, and check CPK or aldolase. All right, it's 41 minutes into this. We in the States and the Western countries in general have the most common etiology of abnormal transaminases due to non-alcoholic fatty liver disease. So that is the commonest liver disease in children and in adults. In the United States, it accounts for being the second most common indication for liver transplantation in adults. And it's actually expected to become the first indication for adult liver transplantation in the next decade if people stop drinking or drink less. So I'm going to skip this and go to evaluating the jaundiced baby. So this is a real case, 2-month-old baby presenting for her 2-month vaccines. The parents were told that the baby looked jaundiced a few days prior to the presentation to clinic. And her birth history was very normal, very smooth delivery, uncomplicated pregnancy and full term, good weight. You examine the baby. First of all, the bilirubin at the second day when they left the hospital was 5. Usually here they get to see the pediatrician maybe a couple of days after they leave the hospital, at 2 weeks, at 1 month. This is the additional clinic visit that was not there when I was a resident, and then at 2 months. And it's very important that you really look at the baby's eyes every single time. As you know, it's very hard to open the baby's eyes, but you have to make every effort that you check the baby's eye, not directly in the eye, but at the angle of the eye, because that's where icterus hides. The baby is exclusively breastfed and is growing well. Of course, one very important question in the history is the stool color. And you may have the card in your pocket. You may just point to the different degrees of yellow and brown and green and all that stuff. And then mom tells you that this is the color of the stool. So that should bring all the flags in the brain to say there is a significant liver problem. So you did the physical exam, the baby's vitals were normal, the growth parameters were excellent, the baby was jaundiced in the angle of the eye, under the tongue, the skin. You did the all physical exam and the liver was slightly enlarged, so slight hepatomegaly. And you did your evaluation, the CBC was appropriate for age. The metabolic panel was normal, and it's always very important to check a metabolic panel, because if the baby had hypoglycemia and acidosis, or one rather than the other, you should be thinking of a metabolic disease rather than, I hope everyone is thinking, biliary atresia. The liver panel showed normal albumin, bilirubin, total is 6, direct is 4.8. So you always write T/direct, and you do not put another slash for the indirect. Alkaline phosphatase was elevated, 700 something. AST and ALT were both elevated. Normal for this age will be around 40 to 50. And GGT, normal for this age, will be slightly less than 100, and it was 230. So definitely there are very abnormal parameters, levels on this liver chemistry. So that takes us to the introduction of jaundice in babies in general. So it's very common in all ages. In the first 2 weeks of life, jaundice occurs in 2.4% to 15% of newborns. It resolves usually by 2 weeks, and it might take longer in the breastfed infants, usually by 3 weeks, but I've seen it lasting 3 to 4 months as well. Cholestasis, which is the direct hyperbilirubinemia problem, in neonatal liver, as a presentation of neonatal liver disease, occurs in 1 in 2,500 to 1 in 5,000 live births. And when we mention the word cholestasis, there are two big categories under that. Either it's a decrease in bile formation, which tells you that there is a hepatocellular problem, or there is decrease or stoppage of the flow, and that's the obstructive jaundice, obstructive cholestasis. How do we define direct hyperbilirubinemia? If the total bilirubin is 5 or less, then D-bili above 1 is abnormal. And if the total is more than 5, then D-bili above 20% of that number total is abnormal. We have guidelines to guide us towards evaluating infants with jaundice. So the guidelines were presented by the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition back in 2004, and they were updated about 3 to 4 years ago in 2017, and they state exactly these words. So any infant with jaundice persisting beyond 2 weeks of age, or 3 weeks in breastfed infants with an otherwise normal history and physical exam, should be evaluated with a fractionated bilirubin. So it's not enough to look at them and say they are jaundiced, or it's not enough to get their total bilirubin level. You always have to fractionate it starting at the age of 2 weeks. And to tell you the truth, I would not I don't see them at 2 weeks, but if I get to see them at 2 weeks, I wouldn't trust the family bringing the baby back a week later. For any reason, slew of reasons, you could choose any of them. So just do it and get done with that. It will give you a relief of not missing any patients that need significant attention early on. So why do we say that? Because prompt evaluation, diagnosis, intervention are vital to optimize the timely intervention that is needed for certain liver diseases at that age. And I'm again hoping that everyone is thinking biliary atresia or obstructive jaundice. So what are the causes of cholestasis in infants? There are big categories, and you can put them under obstructive, infectious, metabolic, toxic, and idiopathic. And the biggest on the obstructive one is biliary atresia. The others are choledochal cyst, stones or inspissated bile duct syndrome, syndromic or non-syndromic paucity of the bile ducts, congenital hepatic fibrosis, very, very rarely to see it at that age, but Caroli's could present early, neonatal sclerosing cholangitis, infections, any of these torch, especially if the baby had like microcephaly, thrombocytopenia, certain skin rash, hepatosplenomegaly, sick baby, smaller baby, then you will be thinking more of infection. Metabolic diseases, newborn screen checks for almost many of them, not necessarily all of them, but think about panhypopituitarism because it could be easily missed. Usually babies are jaundiced, they have abnormal liver panel, they do have blood pressure instability, they have hypoglycemia, they have abnormal ultrasound of the head. As they start getting older, their gaze is abnormal. And of course, their thyroid function is abnormal. Toxic if they are on prolonged use of TPN, total parenteral nutrition, or certain medications. And the last category is idiopathic. When you look at all these and you do not find anything. And the truth is biliary atresia and idiopathic neonatal hepatitis comprise about 1/2 of all cases of jaundice or cholestatic jaundice in the first 3 months of life. So when you have a baby who you already fractionated their bilirubin at 2 weeks or 3 weeks, 3 weeks if they were breastfed, and their fractionated direct bili is low, then you are dealing with indirect hyperbilirubinemia, and that's not our talk. If they have direct hyperbilirubinemia that follows the rules for the definition and they look acutely ill, then you will have to be thinking about infection or metabolic disease. And again, that's not our talk. Our talk is this category where they are infants, they have direct hyperbili, and they are well appearing. So what do we do here? So of course, you're going to take a great history. You will do a great physical exam. Newborn screen, you will call and check what the results were, and then you will start your evaluation. The least amount of evaluation will be what I showed you in the previous slide done like 2 or 3 slides before this one. So complete blood count, metabolic panel, liver panel, GGT, INR. I always add alpha-1 antitrypsin because that can give me the diagnosis right away. And when you do the alpha-1 antitrypsin, and of course I deal with a different population. So the level and phenotype, because you are looking for low level with specific phenotypes that are either ZZ or SZ. These are the ones that can present with cholestatic jaundice in the newborn. And if that was abnormal, then you got your diagnosis. But if the liver panel is abnormal, then you will advance with abdominal ultrasound. And in this ultrasound, you're really not going to be diagnosing biliary atresia, but you are going to be ruling out some other processes like choledochal cyst, that if it's very small, it could be easily missed on an ultrasound, sadly. But if there is a stone or a mass, then definitely you will be able to, hopefully the radiologist will be able to tell. And if a choledochal cyst is suspected, then you will send them for pediatric surgery evaluation. They will get an MRCP, and then they will be evaluated for that process. That's not our talk. Our talk is here. So the ultrasound showed no abnormalities, or they couldn't see the gallbladder. So this is one flag that if they saw it very small or they couldn't see it, maybe, okay, that's another clue towards more points towards biliary atresia. Or they saw other abnormalities, like there were several splenules. That's also a clue to congenital biliary atresia. Or they did not see a spleen, asplenia, another one. Or there is situs. It's very important to know where the liver is sitting, because you really do not want to do a liver biopsy on a spleen sitting on the right side. So there's almost no presentation with situs inversus and direct hyperbilirubinemia in a baby that is not congenital biliary atresia. So if you see no anatomic abnormalities or very few signs, clues towards biliary atresia, you will advance with your evaluation. And the liver biopsy is 95% accurate for the diagnosis of biliary obstruction, that the biliary atresia is the most common of it at that age group. And then for those patients, you will refer them for further evaluation for the 100% accurate test, which is the cholangiogram by the surgeon. If there were no signs on the liver biopsy of biliary obstruction, then you are probably, or your baby, your patient is dealing with another process. For example, idiopathic neonatal hepatitis does not have the manifestations of biliary obstruction on the liver biopsy. Having said all that, the liver biopsy needs to be timed. So biliary atresia will not, the manifestations of it will not show on a liver biopsy at the age of 3 weeks or 4 weeks, or sometimes even 5 weeks. The pathologists always say it needs at least 6 weeks to be present for these abnormalities, histopathologic abnormalities, to be seen on the liver biopsy. The other thing is, for example, if the patient had alpha-1 antitrypsin deficiency, those globules that are supposed to be seen on liver biopsy will not be seen at the age of 6 weeks. So you might be sending a patient for Kasai who really does not need that operation. So always try to make a full evaluation and be cognizant of abnormalities and timing and all that stuff. All right, so why is this important? And I do not sadly know what the incidence of biliary atresia is in Palestine, but I do remember one Palestinian patient from Ramallah who was transplanted at our hospital, but that was in the old days. Biliary atresia is a progressive fibro-obliterative liver disease that develops within the first few weeks of life. It leads to obstruction, usually of the extrahepatic biliary system, and extends proximally into the intrahepatic biliary ducts and leads to liver cirrhosis. It's seen in 1 in 5,000 to 1 in 18,000 live births. Here we see it more common in Asian and in African American girls in general, more commonly affected by boys, like 1.4 to 1 is the ratio. And you should not really miss it in premature infants. I think the old thinking was it doesn't affect prematures, but it does. If left untreated, then it will lead to liver cirrhosis and death by the age of 2. It is the most common indication for liver transplantation in general, probably all over the world, and prompt diagnosis is very important, as the best treatments with Kasai are performed at around the age of 30 to 45 days of life. There are before the types. So the pathogenesis, we think it's an immune mediated. So it means that the liver at one point saw an infection intraperitoneally. We think it is a viral infection that gets contracted at around 2 weeks of age and hits the biliary system, and the body tries to clear that infection, but the way it clears the infection is through an immune-mediated process that sadly leads to fibrosis and scarring of the biliary system. This is the most commonly accepted theory, at least thus far. And the second big category of pathogenesis is the intrauterine problems, mainly through defective morphogenesis of the biliary system. And it's more common to have the first one rather than the second, and those patients are called the acquired biliary atresia or perinatal biliary atresia, where they do not have congenital anomalies, and that is seen in 80% of the situation. 20% of patients have another congenital abnormalities. I mentioned a few of them. So biliary atresia splenic malformation, where they do have asplenia or polysplenia. They could have malrotation or cardiac anomalies, and the other ones that are congenital will not have laterality defects, but they could have genitourinary or GI anomalies, like atresias in general, esophageal, jejunal, duodenal, could be seen in patients with congenital biliary atresia. Do not be deceived if you see the baby growing well, and do not delay evaluation because the baby is chubby and looking absolutely great. Those are the acquired biliary atresia babies. The congenital ones are usually small at birth, and they grow not as good as the other babies who are healthier looking, the acquired ones. Usually they are jaundiced early, like they clear the neonatal jaundice that is there starting at second day of life, and then they get jaundiced past their second week. And again, if you do not look at the angle of the eye, you could very easily miss it because the elevation is not that significant. It could be like a total of 4, a total of 5. total bilirubin, I meant. And the levels that physicians should be able to tell jaundice are at around level of 3. The layperson should be able to tell about jaundice at the level of 5. So because it's an obstructive disease, then the stools will turn white, the urine will turn dark, and you could feel hepatomegaly many times you want very early on. The diagnosis is exactly what I showed you on that baby scenario. So direct hyperbilirubinemia, mild to moderate transaminitis, and elevated GGT. I yet to see a biliary atresia with a normal GGT. Ultrasound could be helpful, but it's mainly not to diagnose biliary atresia as much as to rule out other problems. Again, the choledochal cyst is one, and the second one is stone. HIDA scan, I do not know whether you do HIDA scan or not, but it is a test that we try to stay away from because the best studies consume 5 days, and 5 days added to the 2-month age of the baby means a bad Kasai. And the 5 days are the 3 days at least of phenobarb to enhance biliary flow. And the 2 days are for the study and making sure that there is no flow on the second day. So I would stay away from it. I only use it when the baby's presentation is in the NICU, so very early on, or I won't. All right, so the liver biopsy has specific manifestations, and we are coming close to an hour at this point. So I am going to skip that and tell you that we refer them for surgery to get their Kasai, where the jejunum is cut at around 20 to 25 centimeters away from the ligament of Treitz, and it's brought up to the liver to drain the liver directly. And then the rest of the bowel is sutured here. So it looks like a Y, and that's why it's called the Roux-en-Y. All right. So if untreated, they sadly die very early on. If treated, depending on the time, you refer them for the Kasai. If they get a good Kasai before the age of 60 days, then there is a chance of 70% for them to establish good biliary flow. If they were referred at 90 days or slightly over that, then 25% establishment of bile flow, so significant drop. If they are referred past their 5th month of age, there is no Kasai for them, but they are listed for transplantation. More than 25% have 10-year survival with their native liver. So the 10-year survival with the native liver is around 25%. We say that in general, biliary atresia patients are transplantable at one stage of their life. Literature says about 20 to 25% of them do not get transplanted throughout their life, and we kind of feel suspicious about the stats here. All right, so to conclude, certain liver diseases have a pattern of abnormalities reflected on the liver panel, as I mentioned. Neonatal jaundice should be investigated with fractionated bilirubin if still present at 2 weeks of age. Never say it's breastfeeding or breast milk jaundice. Always investigate further. Most common causes of abnormal ALT in children, at least in our population, I hope you don't have the same, is NAFLD. The prevalence of obesity should not falsely lead to dismissing evaluation of liver pathologies other than NAFLD. So it could be a combination of fatty liver plus autoimmune disease or plus viral Hep B or C or whatever. Detailed history and detailed physical exam are crucial to solve the liver panel abnormality puzzle. Early referral to the specialty or subspecialty is never wrong, and late referral could be catastrophic. And I think with this, I end the presentation. Thank you for listening, and I'm ready to take any questions.
يعطيك العافية دكتور ربا. إذا في حدا من المقيمين عنده سؤال ممكن تستخدم المايك أو الشات. إذا ما في ممكن ننهي المحاضرة إذا ممكن دكتورة ربا إذا في مجال تبعتي لي السلايدز just to share it with the resident.
No problem. All right.
طيب
بالتوفيق للجميع.
شكرا كثير.
يلا السلام عليكم.